Well, the incidence of breast cancer is increasing in our country. In fact, not just in our country, but worldwide. And to talk about how and what we can do, we have with us Dr. Kanchan Kaur, who's the Director of Breast Surgery from the Center of Excellence at the Institute of Breast Cancer at Medanta. Breast cancer is pretty common and is growing. It's growing rampantly. I know that in US, it is approximately about 30% of all women cancers being detected. And I know that in India too, the numbers are pretty much similar, if not more. Also, it is believed that, at least as on date, there is no prevention for breast cancer, but deaths are due to breast cancer because they're not detected on time. So which means that creating awareness of symptoms and reporting it on time is the prime importance. What are we doing about this as a nation? And also, what is it that Medanta is doing about this as an institution?
So, all very pertinent questions, actually. And, the root cause of why, as you said, the statistic that, more women in India die because of breast cancer. I always tell my patients it's not because that we don't have doctors, it's not because we don't have diagnostics, it's not because we don't have treatments. The biggest problem is lack of awareness. So in India, 1 in 2 women will lose their life to breast cancer, which is about 50% chance of surviving after a diagnosis of breast cancer, which as opposed to the West and even China, where 80 to 90% cure rates of breast cancer are achieved. And the main difference is the stage at which cancer is detected. So, there are too many myths in the community, and we as a nation are facing two major problems here. One is the cultural bias, the attitude that the patient has towards their own health when they are healthy. So a healthy Indian patient who does not have a symptom is very less likely to take on a screening test. Screening tests are those tests that are done when you don't have a problem. And we aim to find the disease early on so that treatments can be more successful. And with cancer, it's very important to do that because the longer the cancer stays in your body, the higher stage it reaches, which means it starts spreading in different parts of the body. And then treatments become more and more difficult. So, one problem is that people will not take on screening that well. Even if they take on screening, sadly, the kind of quality assurance that you need to have for screening, the kind of trained doctors that you need to have for screening, we have a huge mismatch there. So you can come to a Medanta, a Max, and Apollo, to a top hospital, or go to a place that offer good diagnostics, like say Mahajan or Colonel Pants, and you are able to get the top quality breast imaging with biopsy. But if you go to a center which does not have trained radiologists, then even at the hand of the best senior radiologist, you may end up missing a cancer. Even at the hand of a general surgeon, you may end up missing a cancer. So that training, which is specific to that organ and to that disease, is very, very important. And I must say, I've been back for 12 years, and it really warms my heart to see that every time now that we have a breast meeting, we have so many doctors, junior doctors, who are interested in becoming breast specialists. So the future is looking bright when it comes to the training bit. But with regards to the infrastructure that we need for screening, that is sadly still not there. So the onus lies not only on the government, because private healthcare is a big stakeholder in healthcare in India. I think a large amount of onus also lies on private healthcare with their CSR to do more community outreach programs. And, it doesn't end with doing a mammogram as screening. And I'll tell you, because I learned from my mistake. When I came back 12 years ago, we had a mammogram van that we used to take and do free mammograms. But what we've realized is that if you can't get a woman with a 3 centimeter, 4 centimeter lump in her breast to come in time to clinic, then how do I convince somebody who does not have a lump in her breast to come and do a mammogram? So the stakeholders, which is the government and the private healthcare, need to increase more awareness. Unless we do that in the community, it's not going to happen. And I think that's where media plays a huge role as well. Nowadays, everything is media driven. So I think that media needs to take the bull by the horns, so to say, because breast cancer rates in India have increased significantly over the past decade because it is a lifestyle disease. And sadly, because we see more and more younger women with breast cancer, it's all the more important that we pick it in time and treat it properly. So, awareness is the buzzword. And I think, like what we are doing at Medanta is what all other hospitals also do, is that we have a huge outreach program where we do lots of awareness lectures. We partner with local communities during the, like if it's Women's Day or October, which is Breast Cancer Awareness Month, we offer tests at subsidized rates. And for the very poor who cannot afford treatments at private hospitals, we do collaborate with NGOs like Indian Cancer Society, where discounted rates are given at Medanta, and the Indian Cancer Society or other NGOs help to pay the treatments. I think going forward, like, if, we need to have this discussion, can't stop. So, like I tell everyone, it's in October. We can't just waken up to the fact that this is Pink Month. It has to, that conversation needs to happen more commonly. And, like on TV programs and in newspapers, if once a month a little, pink box at the bottom says, have you checked your breasts recently? Have you had your mammogram recently? I think things like this will go a long way.
Right. You brought up that most institutes are doing their bit by offering free camps or lower cost of treatment, etc. But sadly, all this is all skewed towards larger cities. What is it that we are doing to be able to reach the tier 2, tier 3? I mean, ideally we need to reach the rural part of India as well. But all these are all skewed towards major cities. I mean, what is it that we are doing?
That is the sad reality of healthcare in India. But the government is waking up, but I think it needs to wake up more to the fact that the cancer burden and the treatment costs of cancer are significantly high and become even higher if you detect cancer late. And sadly, even after spending all that money and all that effort, the results may not always be favorable. So, the government has come up with regional cancer centers, which they are going to have in smaller cities and in outreach areas. But I don't think that is enough until we can open a regional cancer center. But do you have the doctors, the paramedical staff, and the kind of trained people that are needed to be there to kind of take it forwards? So that is why what I feel is that in smaller cities, it's the PHC, the CHC, your Anganwadi worker who needs to be kind of, motivated and, to tell the people and to increase the awareness locally. That is number one. And number two is, again, I would say that private institutes in smaller cities will need to hold hands with the government to take it forwards, because this cannot alone be done, by the government agencies. See, the problem is, if you look at India and if you look at the programs that we've had over the past few decades, look at polio eradication, look at Hum Do Hamare Do, population control, look at TB. There is, because patients weren't taking TB medication, the government has the dot treatment program where they give a person goes home to give the patient the medicine and ensures that the patient has taken the medicine. So if our healthcare, the people, our visionaries have seen to that extent, and even during, the vaccinations for COVID, we saw healthcare workers go up in the mountains and go up to the, the farthest regions of Ladakh to vaccinate people. The problem here is that breast cancer diagnosis relies on a lot of technology. It's not like TB, which is just as simple as chest x-ray. It's not like oral cancer, which is just a clinical examination, right? This requires a good quality mammogram. This requires a good quality ultrasound. This requires a trained person to do a needle biopsy. And then treatment costs start to escalate from there. So I think we all need to put our thinking caps on, and both the private as well as the public sector need to, the government sector, they need to put their heads together to come up with what is the most viable solution for the Indian scenario. And I think the only way this can happen is that you have to empower the local community. For me to go to Tikamgarh and say, oh, you should have a mammogram, and we do a mammogram, and then I don't have anybody there to biopsy a lesion that's been picked on a mammogram, then what good have I done for them? For them to travel all the way to an Apex Institute is not a solution to the problem. So we have to empower the local community, and that has to start with awareness, because when people start asking for it, then obviously facilities have to be provided. You provide a facility and people don't take it, then that's also, if I go and tell somebody in a small town that, and I'll tell you, I'm from Jammu, and I'll give you an example. Whenever I used to go back to Jammu initially, there wasn't a proper mammogram center. We couldn't find anybody to do true cut biopsies, and whenever I used to tell a local radiologist friend, ki, why don't you do it, she said, there aren't enough patients won't come. That patient will travel from Jammu to Delhi for this, but they might not get it done there. Things have obviously changed now, and but if a service provider like a radiologist or a doctor has to provide a service, people should be willing to take it. If I put up a screening mammogram machine and people walk past it saying, I'm fine, I don't want to do a screening mammogram, then that defeats the purpose. So I think it all boils down in the end to making people more and more aware. It has to be an in your face awareness program. Everywhere I look, I should see information on why it is important to self detect, why it is important to screen, and why it is important to come to a doctor the moment you feel a lump. So this kind of awareness needs to be done on a large scale.
So, my question to you is that in the larger cities, this awareness is being done. Yet I don't see too many women proactively going and doing these tests. What do you think stops them? Is it a cultural issue? Is it a fear factor? What is it?
So, even I'm trying to understand this. I end up seeing the most advanced cancers in the most educated women. I have seen professors from Delhi University with lumps that have fungated through the skin, and the patient coming and telling me that I'm fine, I was giving a lecture yesterday. But the moment they take off their clothes, they've got raw ulcers and sometimes even with maggots growing on it. So it is denial. It is the fear of the word cancer. And sadly, I feel that the fear of treatments is way much more than the fear of the disease. Oh, if I have cancer, I will have to have chemotherapy, I will lose my hair, it is painful. So it's okay, let the cancer grow till it reaches a point. On the other hand, if you look at a woman from the village, I know, I can tell you confidently, if I go to a corporate with 100 women, and if I go to a village with 100 women and I give the same talk on breast awareness, a village woman who feels a lump will be at my doorstep the very next minute. Whereas the educated woman will first go online, she will try to find out what are the reasons for breast lumps, she will try to, and her eyes will only see what her mind wants to see. So I think it's here that education sometimes comes in the way of you making a sensible decision. And fear and denial are the two things. Culturally, I think the problem culturally is that as Indians, we are less likely to take on tests, which tell you are unhealthy even though you're feeling healthy. So we are not likely to do that, and that is where the problem starts. So I'll tell you what I have learned over the past 12 years, what my growth has been, that I have found that talking to young girls 18 to 20 years old in colleges has been way much more productive than talking to women who are actually at a high risk of cancer, which is in their 40s and 50s. So when I tell an 18-year-old about the importance of screening, she goes home, she drags her mum out, she drags her aunt out, she drags her grandmother out and brings them to a hospital for this. Because kids nowadays are very clued on to things like this. So if we have to make a change in the cancer scenario in India, then I think the population to target is our youth. And also because in India, 16% breast cancers happen in women younger than the age of 40. And sadly, they are missed. We end up seeing girls in their 20s who've been told, oh, it's just a normal lump that you see at this age, but they actually had cancer. So I think when we talk about awareness, we have to target that group that will actually listen and obviously lead to that change that we are looking for.
Right. So when you speak about, that people are, getting fearful because they are reading a lot of stuff and they are in denial, my question to you is, all this information today is available on the internet, right?
Yeah.
Is internet as a medium doing good by creating awareness or spreading this information, or is it actually doing bad by creating fear and giving access to all kind of information that may or may not be trustworthy? Because you have information coming from you as a doctor, but there is also information coming from someone else who is talking out of their own experience with their family, etc.
It is very true. I think internet is a double-edged sword. And what I tell patients is that when you read something off the net, you are not qualified to interpret it a way that an expert is qualified to interpret it, right? So whenever we tell people to go home and read about something, then you should only go through trusted sites which have been written and peer reviewed by doctors. Please do not visit chat rooms and blogs because they are biased by personal opinion. So many times when we tell patients now that you have to have chemo, the first thing I hear is, पर सब कहते हैं कि chemo में दर्द होता है. That chemo is painful, whereas chemo is not painful. It's an IV medication. It reduces your immunity. It makes you tired. It makes you lose your hair. It is not painful. But because one person said it, and sadly, what happens is that you're more likely to listen to hearsay from friends and relatives and internet than you are from your own expert, because you feel the expert is trying to hide or sugarcoat the side effects for you. So you go looking for the worst that can happen. And sadly, I think internet has played both the role of the devil as because we see so many issues crop up. Because like for breast surgery, if I say yes, it's safe to save your breast, they will go and read a blog about somebody whose cancer came back, and then they'll come back and say, no, we want to remove our breast. So this information is not processed in a way that it should be processed. So always with a word of caution whenever you're using internet or anybody's using internet. It's like if my fridge conks off, I open an engineering manual and try to see how to connect the red wire to the blue wire. I mean, I am not trained to do that. So I think we as a community need to really understand that Dr. Google can do you more harm than good.
So so there are two issues when it comes to spreading or talking about breast cancer and addressing the challenge of the tier 2, tier 3 or the rural parts of the country. One is awareness. So that's addressable by way of internet or better medium or media, or trying to reach out and do camps there. But are we going beyond that? So I know that we have telemedicine and telehealth, online consultations, but are there technologies available to do any remote screening as on date?
So, a lot of things have come in the market but not stood the test of time. Gold standard still remains a mammogram, for which you need a good quality mammogram machine. And not only that, you need trained radiographers who are able to take an entire picture of the breast. So a lot of times what happens is that, so the first problem is, do you have the right kind of machine? The second problem is the person who is taking the mammogram. It's not like an X ray that you sit and the machine will take the X ray. In this, the breast has to be kept between two plates, and the way it has to be kept between two plates, the way the muscle has to come. So, there are a lot of quality assurance things that need to be done to take a good quality mammogram. And so many times we see poor quality mammograms from the community in which the cancer is missed because the entire breast was never inside the field that needed to be taken. So the second problem is that. So how do you remotely access a good quality mammogram? First of all, you need to place a good quality machine there. You need to have trained radiographers there. And then, yes, you could do telemedicine, and like a lot of doctors, radiologists do report mammograms, from a remote this thing. But when we're talking of villages, it's not feasible. I think right now in India, the problem is that you just have to tell a woman, self check. If you feel a lump, then you come to a doctor. That's one thing. The second thing is AI. Can you use AI? So AI has come up in a big way in breast as well. But again, the AI module works only with certain types of makes of mammogram machines, and it's still not proven to be as effective as when it's read by a proper radiologist. The third problem is that a mammogram just gives you a hint of what could be wrong. Characterization of the abnormality happens with an ultrasound. So you need a trained radiologist with an ultrasound machine. Now, what is the problem in India with ultrasound machines? We have a very strict PNDT law. Anybody having an ultrasound machine needs to have a certificate to say that you're not using this for gender detection, that you're not using this to determine that, so that is a very, very big issue. So anybody having an ultrasound machine has to go through reams and reams of red tape with the government, because the government has to keep a check on this, because otherwise female infanticide would cross through the roof. So these are the practical challenges that we face, and that is why it all comes down to that in areas where you still don't have good diagnostics available, you have to make it even more imperative that the local healthcare worker, the local doctor, is trained to be highly suspicious of any lesion in the breast. And what can be done is that they can be connected. So we can make a network of, oh, okay, so you are in Tikamgarh, Gwalior is the nearest to you. Who is the trained breast radiologist in Gwalior? And you have to come here for that. So there should be this system or network of connectivity that we should be able to make till we are able to provide this service exactly in that community. But right now, we do not have the bandwidth or the infrastructure or the trained people or personnel to provide this kind of a high level training screening in the community. So I'll just give you a quick example of UK, where community based screening is done, which means when a woman, when she turns 50, now they've brought the age down to 47. So when a woman turns a certain age, she gets a letter to invite her to come and have a mammogram. And what they do is they place mobile screening units, which are placed in shopping centers like Asda and Tesco, which are big supermarkets. So a woman, when she goes to shop, she can have her mammogram there. And then this mammogram goes to the central screening unit for that area, where three radiologists or two radiologists will read that mammogram, so that we are confident that it's been read correctly. And wherever there is a discordance, a letter will go to the GP or the general practitioner, who will then refer the patient to the nearest breast specialist unit. Now, this is how this system can work. The problem is, in India, we don't even have trained GPs, which I think the government needs to come up in a big way. This whole concept of mohalla clinics in Delhi, if you have proper trained general physicians running such centers over India, then big hospitals won't be crowded with khansi zukam and only those who really need to come to big hospitals will come, whereas a lot of these problems can be sorted out in the community. So there is a way around it. We just need the will of both the private as well as the government sector to implement it. But because this requires a lot of cash inflow, I think that is where things start to kind of start looking very dim.
So, how do we address this cash issue? Because, you know, breast cancer treatment is an
Absolutely.
expensive treatment, and most of the time it requires a surgery, So, is there anything being done, or is there anything that you feel should be done to reduce the cost of treatment for breast cancer?
So, surgery is probably one of the cheapest out of all the treatments that is done for breast cancer treatment. Chemotherapy, especially for patients who have certain type of cancers which are HER2 positive, the targeted treatment can go in double figures of lakhs. And radiotherapy, which is also expensive. So, because cancer treatment for the breast cannot be done by one modality, even if the patient picks it up in the earliest stage, she does need a mix and match of chemo, surgery, radiotherapy. Now, how costs can be reduced, this is this is one question which is very, very difficult to answer. But I think, the kind of money that we spend on so many other things, which is not even useful, I think the government needs to come up, and this can be done only by the government, is to come up with a proper data on which are the areas where we need to do more, starting, in the starting, like in the east we see more cancer, so there what do we need to do? And then obviously the stakeholders like the medical pharma companies that are providing the chemotherapy drugs, what import duty the government is levying on drugs that are imported from the west to treat cancer, although how can we have generics in India so that the cost can be brought down? How do you make it more lucrative for somebody to say, see, because at the end of the day we are seeing healthcare go into a business model. So how does the government then help somebody saying, or more and more people to come up to say, yes, I can adopt this business model for cancer? So for that, things have to be made easy. So if I'm importing a mammogram machine and if I'm paying so much duty on it, would I want to even get it? How much does it cost for me to train my doctors and my staff? How much does the medicine cost? So all these things come in, and I think another thing which is very, very, very important is that we have to get the Indian population more attuned to getting private healthcare insurance. That is so, so important. Sadly, majority of patients that walk in our clinics are not insured, and the moment they get that diagnosis or stamp of cancer, even 10 years after treatment, when we say you are all clear, no insurance company or most insurance companies don't have the courage to come forward to give them that insurance. So I think it's multiple things that we have to look at, and how to reduce costs is obviously something that the government has to look at, and they have to cap. They can start by capping treatments, but then with government hospitals also, the number of trainees that we have in government hospitals, I think rather than having just a few aims and a tata and a pgi, more and more government hospitals have to be made excellence centers for cancer. And say, if in the if in a large district there is an excellent center for cancer, then it can cater to even the smaller areas around it. We still have patients coming from even cities like, say, Lucknow, where there is so much treatment available. They will still want to come out. Why? So the whole idea is that you have to make it a lucrative business model, but with capped treatment costs and reducing the cost of the consumables in this. I think all of that has to play a role in making cancer treatments more affordable. And if cancer treatments start becoming more affordable and patients don't have to think twice, they'll get better treatments. And for a problem that we see with cancer is that for want of better treatments, because patients can't afford, their cancer progresses and they can't be treated. Then the message in the community goes that breast cancer can't be treated. But that's not true. So a lot of things to look at how this can go forwards. I'll give you a quick example of a drug called Herceptin. So 10 years ago, this was only imported, and the cost of one vial was in excess of 1 lakh rupees. So patients had to have 17 of these. So that's just the cost of that vial. Now generics have come up, and this injection is as cheap as 30,000, 35,000 in India. So those things do help to take it forward. And I think even big donors, CSRs of big corporates, that will go a long way as well in helping set up excellence centers for cancer.
Dr. Kanchan, in your while answering the last question, you did mention that there are certain areas which are more prone, and you're getting more cases from these certain areas. Does it mean that there are certain conditions in which there are certain kind or certain people who are more prone to breast cancer than others?
So, see, breast cancer is multifactorial. There is no one particular reason why it happens, but we do know that your genetics and the effect of the environment plays a huge role. So, like in the eastern part of the country, it could be with due to lifestyle factors. It could also be due to genetics. So, in fact, we also need to do a genetic study for the Indian population to understand, because we keep extrapolating genetics from the West. So, there are certain groups of women, certain populations that are more at a risk of developing this. So just let me give you a random example. Cities are more prone, women staying in cities are more prone to developing breast cancer than women staying in rural areas. And we know that the four metropolitan cities in the country now top the number of breast cancers in the country. So, obviously, this is an indirect hint that there is something to do with the environment and lifestyle factors. But nobody can put a finger on it. The only definite that we know is the what Angelina Jolie had, which is a genetic abnormality. And so, families in which cancer, there's a strong family history of breast cancer, then we can do the gene test to find out. But in 70 to 80% patients, there is no family history. So it is a lifestyle disease.
So when 70 to 80% of the cases we do not have a family history, how important is genomic testing or DNA testing for people? I mean, I know that there is a huge focus on genomics, especially for oncology.
So, genomics, again, um, is like a Pandora's box, right? If you don't have a strong family history of breast or ovarian cancer, and you go and randomly get this test done, and sadly that is what is happening in India. It's being sold as a test that you can do to find your risk of cancer anywhere in the body. And because we believe in our janam patris, we believe in our in the genome results. And the problem there is that a lot of times, not a lot of times, but quite a few times, the result comes back as variation of unknown significance, which means there is an abnormality, but experts don't know whether it should be actioned upon. And that is where the problem starts, because then you have a sword dangling over your head. So the rule of thumb is that we do not randomly offer genomic testing to somebody in the population who does not have a family history. It is not to be done. Only those who have a family history should meet with a genetic counselor, get a pedigree chart made to understand what kind of cancers were common in their family, and then those specific genetic mutations are looked for. And ideally, it should be looked for in the patient first. So, say the mother. If the mother doesn't have that abnormality and she had breast cancer, then the daughter cannot have the BRCA mutation. Okay, random mutations also occur. They don't always have to be carried down generations. They can happen randomly also. So if a woman gets breast cancer at a younger age, even if there is no family history of breast cancer, we do like to look at the genomic structure to understand if there is a genomic mutation which was not inherited, but which is what we call sporadic mutation. So it wasn't inherited, but this mutation happened in this patient, and this can then go on to the next generation. So those are the patients. We have very specific set guidelines for who is to be tested for these genetic problems. And in India, we do have a huge pool of labs that are doing this test very well. So see, this is the problem, because this is a test which which we are able to do without too much of input of resources, we are able to set up excellent centers like this where genomic testing is done. But when it comes to the complex area of diagnosing and treating breast cancer, where the financials take a completely different picture altogether, that is where then this suffers. So it's not like India doesn't have the bandwidth to do this. It is just that, is it going to be lucrative? Is it going to be as cost effective to be doing this for the person who is actually setting up, say, a cancer excellence center? So that is where the problem starts to come.
Do we have enough breast cancer specialists, surgeons in our country?
There can never be enough specialists in a country like India, where the population is the kind that it is. But it's very, very heartening to see how cancer as a specialty, and then its sub and super specialities which are organ specific. So any good hospital now will not have a general oncosurgeon. They will have a breast oncosurgeon, they will have a head and neck oncosurgeon, they will have a gynae oncosurgeon. So the more super specialized it becomes, the care becomes better. But then sadly, it then all goes up to the apex where super specialists are very unlikely to go to tier 1, tier 2 cities. Why? Because the facilities that we have in a hospital like Medanta, I may not be able to get in a hospital in somewhere remote area. So that is why then, if I have to give the best to my patient, I have to bring them to a center which is offering a good mammogram, good pathology, radiotherapy facilities, and all of that. So I think if we start off, and I always come back to this, if we start off with awareness about, amongst women, that breast cancer is extremely common, and if you have a problem in the breast, you must seek a doctor early. Even if you don't have a problem, from the age of 40 onwards, you must get mammograms. I think the moment this message, you know increases in communities, then you will see centers mushrooming up which are offering these facilities, and you will have enough specialists then to treat it.
So, Dr. Kanchan, I remember I had interviewed you earlier as well, and where we spoke about various questions related to the disorder and what needs to be done. And we spoke about that in many cases the breast is removed. Right now, this creates, and we spoke about that this creates a lot of mental trauma among women when they are told that their breast will be removed. uh, what role does mental health uh, play when you are treating your patients?
So, in the West, you have to have a counselor sitting in your clinic when you're breaking bad news and giving the diagnosis. In India, try doing that. The poor patient is surrounded by relatives who are over anxious, underinformed, heavily biased, and they make it so difficult, and they create this haze that the doctor also finds sometimes difficult to dissipate. So a lot of times, the first thing I do is, if I find relatives like this hampering my consultation, I tell them to go out and I take a consultation with my patient in the privacy of my room without anybody sitting there, because then we are able to gauge the mental status of the patient. So you have two kinds of patients: one who, even with a 5 millimeter cancer in the breast, will come and say, I don't care. I want a total breast removal, because keeping the breast is going to give me more mental agony. Every time I look at it, I will feel the cancer is going to come back. So you do have that, proportion of patients as well. Thankfully, that doesn't form the majority of what walks into our clinic. And then obviously there are women who walk into the clinic, and even if they have lumps which are huge, they do not want their breast removed, and they want us to find a way to help save their breast. So it is a very complex clinical consult which involves obviously the surgeon and the patient and her spouse. And then we do have counselors on board, and then we have breast cancer support groups where other patients who have had similar procedures. The patient is given a chance to talk to them, to understand. She's taken through pictures of mastectomies, of reconstructions, and made to understand that if mastectomy is her only option, then the option of reconstruction is also there. The sad story there, however, is cost. Because when we bring reconstruction into the picture, it does increase the surgical cost by 2 to 3 times. And a lot of women in the end who know they still have to spend on chemotherapy, radiotherapy, then want to delay surgery, the reconstruction surgery, for a later date. And I will tell you, hardly 1% will come back for a delayed reconstruction, because then once their treatments are done, the last thing they want to do is get readmitted in hospital again for a reconstruction. So it's a very, very complex dialogue, which is completely individualized to every patient, because every patient is different. And mental health, or the mental well-being of the patient, with the kind of procedure we choose, especially with mastectomy, we have to tread extremely carefully. We have to handhold them. And I must say, most of them, if you handhold them well, tend to take it on. It's not that difficult then, because they are also looking at the other side, where the confidence that they get that they are cancer free somehow kind of helps balance the mixed feelings of not having a breast. But the option of reconstruction at a later date always remains, even if they haven't chosen it at the time of initial surgery. And I think some women just live on that hope, and that they never come back. But at least at the back of their mind, they know that when they are really, really being bothered by this, they can always come back and get their breast reconstructed. And that is why the consults in a breast clinic are they don't start and end with, yes, you have cancer and this is your treatment. There is so much that needs to be discussed. In a young patient, we have to discuss fertility issues. In women who need breasts removed, we have to discuss reconstruction. Then a lot of women in their premenopausal age are made postmenopausal by the treatments. The side effects of postmenopausal status at the age of 35, 40, that comes into the picture. The social sexual life of the patient, so many issues come into play. And that is why a specialist unit goes a long way in treating breast cancer, because we are geared to deal with all of this. We have specialists on board, physiotherapists, counselors, and we help patient to take the patient through the journey. And sadly, I think, if I can say, with a heavy heart, that hardly 10 to 15% of cancer patients in India are able to get that kind of care, because we still don't have enough specialist units, which I do hope we will have in the near future.
Usually, breast cancer has always been associated to women. For some reason, it has been there. But what is the percentage of male patients with breast cancer that you typically find in India?
So it's a standard statistic. 1% of all cancers happen in men. So if I see 100 breast cancers, one will be a man. Having had said that, I've operated on 2 males last week, which is not the usual norm. But so 1%.
So my last question to you, what is it that you as an individual and Medanta as a premium institute, which is running a center for excellence for breast cancer, is doing or is planning to do to make this bringing efficiency in the system or reducing cost? What is it that you are intending to do in the coming times?
So I think this question is best asked from Medanta administration. But yes, I think that will to provide the best standard of care is there, and that is why we have group of trained specialists who are allowed given enough time to go and get more and more training in their field, so that they are up to date with whatever is the latest in the field of cancer, be it radiotherapy, surgery, medical oncology, radiology, pathology, so the entire spectrum of diagnostics and treatment. To make the journey easy for a patient, in fact, our Cancer Institute has helpers on the floor who will guide a patient through tests and all, the nitty gritty of getting their tests done and understanding them, because that patients get lost in a hospital like Medanta if I tell them to go to 10 floors to get 10 tests done. So we have these coordinators who coordinate appointments and tests and everything for them. And for patients who are not very affording, we have direct approach to Dr. Trehan, our CMD, who is always very big-hearted and helpful, and we do manage to reduce costs of treatment for patients who are truly deserving. We have partnered with Indian Cancer Society, and patients who come through them are allowed a cheaper rate for their medicines, which they are allowed to get from outside, which is obviously at a cheaper rate when they get it from chemists. So that is what is allowed for them. And as I told you, for surgeries, we get a discounted rate along with NGOs pooling in money so that we can provide care to the patient. But we have to understand that this is just a tiny drop in the ocean, because again, being a private setup, there is a limit to which costs can be reduced. And it's only the very, very deserving, who actually get the treatment and tests done at Medanta. But we are also very active in the community. We have a CSR program where we go out, do unlimited awareness lectures and discounted tests for patients coming through camps. And I will tell you something which was very close to my heart, and I'm about to implement it very soon with an NGO called Yes to Life. I am going to be starting a free breast cancer program with the Haryana Health Department, where we have got a dispensary from them, and it's a breast cancer center in the heart of Gurugram. And we are going to start off with diagnostics, providing support to poor patients in the community who don't even know that there is something like a breast cancer support, and slowly build it to a point where we can, if possible, to whatever extent, reduce the costs of treatments for patients who are not able to afford. And if this model works here for us, then we can look at replicating it in other centers as well. And that is what I was talking about. This partnership between private and the government has to happen. Otherwise, it is very difficult to take the next step forward, because the onus cannot be on private healthcare institutions alone. It just cannot be.
Absolutely, I totally agree with you, and it's heartening to know that you as an institution is taking those steps. Thank you so much, Dr. Kanchan, for taking our time to speak with us.
Thank you so much. Always lovely to be able to vent out, because this is my if that is one mission in life I have now, is that I want to be able to find ways on how to make it accessible to the community to get tests and treatment for breast cancer done. So hopefully in my lifetime, if you interview me 10 years down the line, things will be better than they are today. Thank you so much.
Absolutely. Thank you so much, Dr.
Thank you. Okay.